Today we are going to talk about aortic dissection. So we'll talk about some anatomy, imaging, and some special cases of aorta. Aorta is the largest artery of the body which carries the oxygenated blood from the left ventricle and supplies it to all the parts of the body. The aorta initially is 1 inch wider in diameter. The aorta is classified as the largest elastic artery. Can be divided into 4 sections: ascending aorta, and it is derived from neuroectoderm. Aortic arch, thoracic aorta, and abdominal aorta, they are derived from mesoderm. The first 3 sections are confined to the thoracic cavity and together create a thoracic aorta. The aorta terminates at the level of L4 by bifurcating into left and right common iliac arteries. And this is a diagrammatic representation of the aorta. And these are the normal anatomical size variations in the aorta. Ascending aorta originates from the upper end of the left ventricle and continues as the arch of aorta at the sternal angle, about 5 cm long, enclosed in the pericardium, and begins at the level of the lower border of the third costal cartilage, runs upward, forward, and to the right to continue as the arch of aorta at the level of the sternal angle. The aortic dissection is a serious condition in which there is a tear in the wall of aorta. In aortic dissection, the blood seeps into the media, separating the media. The outer layer also contains the media and adventitia. During an aortic dissection, the inner layer of the aorta tears, letting the blood in where it usually doesn't go, and this causes the inner and the middle layers to separate or dissect. If the blood bursts through the outer wall of the aorta, it's life-threatening and needs immediate repair. And this is the classification of aortic dissection by Stanford. And there is also a DeBakey's classification which is used. So goals of aortic dissection: the patient salvage, there should be no tamponade, no MI, fix the valve, identify and seal the tear, and long-term survival. And if there is intramural hematoma, nothing needs to be done. The risk factors: the pathogenesis of the aortic dissection is not well understood. There are several theories that might explain the etiology of the intimal tear that results in dissection. An early theory was cystic medial degeneration, where the media is abnormal, but as the abnormality has been found only in the minority of the patient with acute aortic dissection, this theory has lost ground. The later theories identified the atherosclerotic ulceration penetrating to the media as a source of the intimal tear, but again these are uncommon at the site of intimal tear. Finally, the intraluminal hematoma resulting in the bleeding of the vasa vasorum into the media is thought to account for sufficient stress to cause the intimal tear. The risk factors include the age, more than 60 years, hypertension caused by chronic primary hypertension, Cushing syndrome, cardiac output, high cardiac output state like pregnancy, connective tissue disorders like Ehlers-Danlos syndrome, atherosclerosis, bicuspid aortic valve. It could be iatrogenic and competitive weightlifting and trauma. Clinical features. So the dissection usually gives a sudden and severe tearing pain radiating from the chest throughout the back and sometimes the neck and the arms. About 30 to 40% die immediately. A minority of the patient present with asymptomatic and usually chronic dissection picks the incidental finding on CT. The complication of the aortic dissection include the arch vessel occlusion caused by a stroke, myocardial ischemia, hemopericardium, and occlusion of the vessels may lead to upper and lower and mesenteric and renal ischemia, paraplegia, and rarely acute dissection cause SVC syndrome, hemoptysis, airway compression, and Horner's syndrome. So the thoracic pathology, so dissection can happen in aortic aneurysm, and an aneurysm is defined as the permanent localized dilation of the artery at least 50% compared to the normal. The dimension of the normal aorta is are uncorrected to the body mass index. Annulus 2.2, sinotibial junction 2.4 to 3, mid ascending aorta 2.6 to 3, and mid arch is 2.4 to 3.1. The aortic aneurysm could be a true aneurysm which involves all the layers. False aneurysm or pseudo aneurysm has an outer layer consisting of adventitia. Mycotic aneurysm is an aneurysm caused by the result of infection. The risk factor for aneurysm formation is usually due to the loss of elasticity and tensile strength in the medial layer of the aorta, which is normally composed of elastin, collagen, and smooth muscle cells, and degrades, synthesize the elastin and ground matrix. Elastin content is the highest in ascending aorta and the media and becomes thinner distally. In typical aortic aneurysm, there is a fragmentation of the elastin fibers within the media, and the loss of the smooth muscle cells causes cystic medial degeneration. And the ascending aorta expands and recoils with systole and diastole respectively, maximizing the forward flow. When elasticity is lost, the aorta begins to dilate, and the aorta dilates normally with age. And the risk factor for aneurysm formation include the age, hypertension, atherosclerosis, smoking, connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, Turner syndrome, Loeys-Dietz syndrome, cystic medial degeneration, aortitis, and aortic stenosis, bicuspid aortic valve. So it has two mechanisms. One is the post-stenotic dilation and increased medial degeneration in the bicuspid AV valve. Other is syphilis and bacterial infections and trauma. Connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, and there could be familial aneurysm which presents with one third are asymptomatic, and half of the patient present with anterior chest pain. Acute onset of pain suggests dissection or impending rupture. There might be hoarseness from the arch aneurysm, and examination is sometimes unremarkable. So, for coming to the topic, diagnosis of type A dissection, the imaging, the primary role of the diagnostic modality is to differentiate between the type A dissection and type B dissection. A secondary role in assessing the extent of dissection, which dictates the surgical approach. As a broad rule, the center planning to refer for suspected acute type A dissection should use the imaging modality in which they have most expertise. Investigations include the hemodynamically unstable patient where there is a risk of suspicion. Patient with a crushing chest pain already known to have aneurysm is reasonable to transfer directly to the operating room, anesthetize, and perform TEE. If TEE is positive, lines are placed so that it is possible to proceed directly to surgery. If TEE is negative, invasive monitoring will allow the patient to undergo additional investigation. The more investigations, CTA can be obtained quickly with a plan to transfer the patient directly to operating room without delaying to insert monitoring lines and treat the pressure of CTA positive. The blood tests are usually normal and raise creatinine and LFT sometimes to indicate the chronic hyperperfusion states, and the raised troponin suggests involvement of coronary ostia. ECG should be inspected for the signs of ischemia, but 30% of the patients in whom the coronary ostia have involved EKG changes are non-specific. The chest X-ray may show the widened mediastinum, cardiomegaly secondary to pericardial effusion, signs of the pleural effusion, usually on the left side. Coronary angiography is difficult and hazardous, and the same information can be obtained by CTA. So 30% of the patient die immediately, 50% die within 48 hours, and operative mortality is 20 to 30%. So the goals of the aortic dissections is patient salvage, no tamponade, no MI, fix the valve, identify and seal the tears, and long-term survival. and intramural hematoma, we have to do nothing. So, contraindications to surgery is advanced age, incurable malignancy, chronic dementia, AMI, coma, stroke, paraplegia, renal failure, and other severe diseases. So the aim of the surgery is to treat and prevent the cause of death, and acute type A dissection is an indication for emergency surgery, and subacute type A dissection is indication for urgent surgery. The main variable to think about are the extent of resection, a root or arch is required, cannulation strategy, the need for circulatory arrest, and can the aorta be clamped, which dictates the sequence of distal versus proximal anastomosis, as well as need for deep hypothermic circulatory arrest, the myocardial protection strategy, and venting. The impact of each of the conduct of surgeries outlined in the discussion, and there are many possible scenarios. The arch and root are normal, a simple interposition graft using the aortocaval cannulation, direct ostial and retrograde cardioplegia, no deep hypothermic circulatory arrest. The distal aorta is aneurysmal interposition graft with hemi-arch replacement with deep hypothermic circulatory arrest using the axillary cannulation and ostial retrograde cardioplegia. Root is aneurysmal root replacement with or without deep hypothermic circulatory arrest. Arch is involved deep hypothermic circulatory arrest, selective or retrograde cerebral perfusion. Monitoring lines. At least two arterial lines are helpful, as the dissection of the cannulation of the arch of aorta distal vessels may lead to misleading arterial pressure measurement. A right radial line is used for right axillary cannulation to detect hypo or hyperperfusion the right arm if the side graft cannulation technique is used, but the pressure transduced from during the bypass may bear a little correlation with the systemic pressure, especially in the right cannulation. Left axillary and femoral lines give more accurate central pressures than the radial lines, and which is usually damped by the end of the case. Prepping and draping. Drape for the full sternotomy, but include the lower neck at the field, and the case of incision has to be extended for the arch involvement and the whole infraclavicular area to allow the axillary cannulation. Shave and prep both the groins for possible cannulation. Prep and expose thighs in case of saphenous vein is required. Incision. A type A dissections are repaired via the median sternotomy and may need to extend into the neck, so always prep and expose these areas well. Cannulation. A very large aneurysm may make access to RA difficult and may preclude safe aortic cannulation. The main options are central cannulation with venous return, femoral caval cannulation, femoral cannulation, axillocaval cannulation, and bicaval cannulation. The myocardial protection, depending on the nature of the ascending aorta, it may be preferable not to clamp and bypass is commenced and the patient is cooled. The heart fibrillates around 32 degrees and retrograde cardioplegia is given. For venting, the LV vent is and the right superior pulmonary vein is usually much less difficult to access once the bypass is commenced. Pump sucker placed in the LV and aortic valve cooled to 18 degree. Deep hypothermic circulatory arrest is used. In the acute setting, it is usually safest to focus on treating an immediately life-threatening complication of the ascending aortic rupture, and resection is limited to the proximal arch, and the valve involvement addressed by the resuspension and the commissures rather than attempting to root replacement. And if the dissection extends to the coronary sinuses, a bioglue and a careful proximal suture line on the interposition graft should prevent the progression, as the coronary ostia are usually spared. It is safe to clamp the ascending aorta, avoid the large aneurysm where rupture is at risk, and the proximal anastomosis can be completed while the patient is cooled. The distal anastomosis can be performed with the cross clamp on, and there is no need for circulatory arrest of, and deep hypothermic circulatory arrest is required depending on how far distally the dissection extends and whether the aorta can be safely clamped. Cannulation options are discussed in this discussion. If interposition graft is used, this technique is preferred for DeBakey type 2 dissections not involving the aortic root. It supersedes the older graft inclusion technique where the aortic tissues was preserved and wrapped around the interposition graft. Setup is discussed here. The bypass is established via the aortic cable cannulation. Perfusion is begun to cool the patient to 28 degrees centigrade and the aortic clamp is placed just proximal to the innominate artery. Cardioplegia is given antegradely by medicat cannula into the root and retrogradely into the coronary sinus cannula to arrest the heart. Open the aorta transversely and use a pump sucker to vent the heart. Inspect the aortic lumen and the aortic valve. If the dissection extends past the sinotubular junction, this will need reconstruction. If intimal tear extend distal to the cross clamp, circulatory arrest is required to inspect the repair the distal ascending aorta, in which case continue cooling to 18 degree. Give cardioplegia directly into the coronary ostia and retrograde. Transect the aorta 5 to 10 millimeters distal to sinotubular junction, and if the dissection extend into the sinotubular junction, reconstruct the aorta using the bioglue and reapproximate the intima and media and secure hole with fluoroproline running stitches anchoring the strip of PTFE around it. So transect the distal aorta and bevel of Dacron tube to match the size. If the distal anastomosis is to be carried out without the cross clamp, one has to stop the bypass, and when the temperature is 18 degrees centigrade, clamp the lines to stop the vent and remove the cross clamp, and anastomosis should take less than 20 minutes. Sutures the distal cuff and ascending aorta to the distal graft, and felt is stripped in the same way as the proximal aorta, starting the forehand inside out. Forehand inside out graft felt aorta and a few bites further away from 6 o'clock. Running towards until one takes the bite into and take other arm sutures and run up wall furthest away from 2. As the distal anastomosis is completed, the graft is allowed to fill retrograde and remove the arterial line clamp, and now the perfusion is to come on 500 mils of flow and shake the graft so it de-airs fully and suction debris come on further and flow and tie, and then it comes fully unclamp the venous line vents and resume bypass. Place a vent in the graft and carry out standing and de-airing. So for hemostasis, one has to look at the spurters and fix with fluoroplagiated proli with a flow down for everything else pack and reassess after the protamine has been given, and any coagulopathy, usually platelet dysfunction, completely corrected using the proline to treat non-surgical bleeding, and carbol patch could be used in that condition. Coming to type B dissection, type B dissection have initial hospital mortality about 10%. About two-thirds remaining patients will have no complication requiring the operation, and 50% of unoperated patients, however, dies within 3 to 5 years of rupture, and the complication related to end organ ischemia operative mortality is 5 to 15%. So medical treatment is primarily aimed at maintaining a low arterial blood pressure and reducing the force of ventricular ejection. The labetalol 250 milligram in 250 mils and 5% dextrose at the rate of 2 to 8 milligrams per minute is best agent for in hospital. Complications requiring emergency surgery include aortic rupture, periaortic mediastinal hematoma, hemothorax dissection in the pre-existing aneurysm, rapid increase in the aortic diameter, ischemia of the limbs and viscera, intractable pain despite the optimal medical management, progression, Marfan syndrome. Contraindications to surgery. Contraindications to surgery include advanced age, incurable malignancy or other terminal illnesses, chronic dementia, severe pulmonary disease, favors stenting over surgery, irreversible profound brain injury, new stroke, paraplegia, renal failure, acute limb and visceral ischemia. Complications of surgery, death, especially in elderly patients, stroke. The endoluminal stenting, a proportion of the patient with acute or chronic type B dissection are candidate for endoluminal stenting, and indications. The precise indication of endoluminal stenting is still matter of debate, but most patients, particularly older patients with multiple comorbidity, should be considered for stenting for the purpose of stenting of the true lumen to seal intraarterial stenting of the static obstruction of the branch artery, ballooning fenestration of the dissection flap, and stenting of the true lumen for visceral and lower body hyperperfusion. Stenting of the true lumen to enlarge the compression of the true lumen. Complications of the endoluminal stenting include MI, paraplegia, stent migration. So aim of the repair is to resect as much as involved aorta as possible. So one has to go full bypass, allow the control of the blood pressure, and option of deep hypothermic circulatory arrest, which involves the ability to control proximal portion, especially if the arch is involved, and eliminate the bleeding collaterals, as well as allowing the BP to control lower body to be perfused. Partial left heart bypass also allows blood pressure control and distal perfusion, but without coagulopathy associated with full heparinization and use of oxygenator. The arterial return is to femoral artery, and the venous drainage is from inferior pulmonary vein or the left atrial appendage. Clamp and go avoids the coagulopathy and inflammatory picture associated with bypass, but relies on the fast anastomosis, as the lower body is warm ischemic time is longest with this technique, and risk upper body hypertension once the descending aorta is clamped. So one has to ensure that the patient has external defibrillator pads, right and left radial lines, prep and drape, and make left posterior thoracotomy, thoracoabdominal incisions, and once the thoracic aorta is exposed and secured, left subclavian artery, preserve the left vagus and left recurrent laryngeal nerve, the thoracic aorta is freed. Once fully heparinized, go on bypass and place the vascular clamps and maintain the right radial artery pressure 100 to 130 and transect the aorta 1 centimeter distal, and for proximal anastomosis use Plegeter 4 of proline and elephant trunk, and within the anastomosis complete reposition of the proximal clamp and the proximal anastomosis satisfactory transect the aorta. Depending on the level of the extent of dissection, the renal celiac arteries may be reimplanted into the Dacron graft at this stage. Vein of bypass and reverse heparin. So the recommendation for the type A dissection is timely diagnosis and ascending aortic replacement, including the primary aortic tear, open distal anastomosis, ascending aortic and aortic arch replacement is indicated in patient of type A aortic dissection. Aortic root replacement is indicated for patient with acute type A aortic dissection, arterial inflow cannulation for cardiopulmonary bypass, long-term radiological surveillance, and long-term annular echocardiographic surveillance is recommended. Descending aortic dissection, aggressive acute medical management and aggressive monitoring, and prepared guidelines are unclear. Ascending aortic arch recommendation, all patients with suspected thoracic aortic disease on the basis of family history should be imaged, and the patient with bicuspid aortic valve should undergo imaging And all patients with Marfan syndrome and Loeys disease syndrome and mutations are associated with aortic disease, and first-degree relatives of the young patient with bicuspid aortic valve or genetic mutations are associated with aortic disease. All patients for whom planned elective valvular surgery is planned who have associated thoracic aortic disease should undergo preoperative cardiac catheterization. Surgical repair is recommended when ascending aorta or aortic root exceeds 5.5 centimeters. For the patient with Loeys disease syndrome or confirmed TGFBR1 or TGFBR2 mutation should be evaluated for repair of the aorta. Separate valve and ascending aortic replacement are recommended for patients without significant aortic root dilation for the elderly patient. Aortic arch, its location is in the superior mediastinum. The aortic arch is a continuation of the ascending aorta and begins at the level of the second sternocostal joint, and it arches superiorly, posteriorly, and to the left before moving inferiorly. The aortic arch ends at the level of the T4 vertebra, that is the level of the sternal angle. The arch is still connected to the pulmonary tongue by ligamentum arteriosum and the remnant of the fetal ductus arteriosus. So there are three major branches beginning from the aortic arch: the proximal to distal, the brachiocephalic trunk. The first and the largest branch that ascends laterally to split into the right common carotid and right subclavian arteries, and these arteries supply the right side of the head and neck and the right upper limb. The left common carotid artery supplies the left side of the head and neck. The left subclavian artery supplies the left upper limb, and occasionally a fourth branch of thyroid ema artery or vertebral artery may originate from the arch of aorta. Descending aorta. The descending aorta is a section of the thoracic aorta which is contained in the posterior mediastinum. It originates leveled along with the lower boundary of the T4 and consistent with the aortic arch. Initially begins at the left of the vertebral column but approaches the midline as it descends, and it leaves the thorax via the aortic hiatus and the diaphragm and becomes the abdominal aorta. For the patient with chronic dissection, particularly if associated with connective tissue disorder but without significant comorbid disease, the descending thoracic diameter exceeds 5.5. Open repair is recommended. For the patient with degenerative or traumatic aneurysms of the descending thoracic aorta exceeding 5.5, saccular aneurysm or post-operative pseudoaneurysm, endovascular stent grafting should be strongly considered. For patients with thoracoabdominal aneurysm in whom the endovascular stent graft options are limited and surgical morbidity is elevated, elective surgery is recommended if the aortic diameter exceeds 6.0 centimeters or less. Connective tissue disorder such as Marfan syndrome, Loeys disease syndrome is present. For the patient with thoracoabdominal aneurysm and with end organ ischemia or significant stenosis from atherosclerotic visceral artery disease, an additional revascularization procedure is required. Special cases: pregnancy with or without genetic disease, counseling before pregnancy, adverse event during pregnancy and delivery, genetic Marfan's Loeys disease syndrome, bicuspid valve testing, and poor endovascular repair options and coarctation. Plan the anatomic approach, imaging method, and special cases: bicuspid, pregnancy, and genetic disease. Hope you have enjoyed. If there is any feedback, please let us know and we can make another video. I know it's an extensive topic and it's very difficult to summarize in a brief lecture. Thank you very much.